morning, everybody. Got to bring the mic so I can. My name is Carol McDaid, and I'm a woman in long-term recovery. And long-term recovery for me means that I've been alcohol and drug-free for over 15 years. Thank you. And my recovery has allowed me to become a wife, a stepmom, a small businesswoman, and the reason I'm here tonight, like many of you, I'm an advocate for recovery. I'm going to kind of just tee things up for tonight and give you some of the very basics about what the Parity law is, why there are problems with it, and why we really need your continued help and support. And while I may have been one of the advocates in the trenches tolling, I would be remiss if I didn't say the driving force and the spiritual guru of the Parity and recovery movement in this country right now, Patrick Kennedy. So let's talk a little bit about what it is and why we need it. So you'll hear us say Parity, you might hear us say an acronym called MAPIA. What this is, it's referring to a law that passed in 2008, thanks to Patrick's work and the work of his father in the United States Senate, that requires health plans to treat addiction and mental illness like other medical conditions covered under health insurance. That law passed in 2008. It became fully effective in 2011, and we were able to get provisions that also require parity. And when I say that, I mean that diseases of the brain should not be treated any differently than the diseases of the body, that there's no medical reason for the disparate treatment. So when we talk about parity, what we are referring to is that these conditions, behavioral conditions, addiction and mental health, have to be equal to the treatment and health plans for other medical conditions. And if you look it up in the dictionary, that's what it says, the state of being equal, and especially regarding status or pay. And the pay part is very interesting, and we're going to get into that tonight. Many of you have probably had trouble getting your behavioral health care needs paid for, and that reimbursement rates are a part of this law. So why did we even need this law? There has been historic discrimination in access to care for mental health and addiction in this country. What do I mean by that? You have to, historically, you might have a $10 or $20 copay to go see a physician. And then on the behavioral health side, you might have had to pay half the cost of the visit as your copay amount. So there were uneven out-of-pocket spending amounts that consumers were required to pay. And one of the issues that I think people really aren't aware of, and it's really just an outrage to me, is that individuals who have addiction, severe addiction and mental illnesses, die on average nationally 30 years earlier than people without these conditions. Let me repeat that so people kind of wrap their brains around that. People who have severe addiction and mental illness die on average 30 years sooner than people with other medical conditions. For some people, that's nearly half of a life cut short. If this was another illness, people would be rioting in the streets for access to the care to keep the life expectancy equal. But when it comes to addiction and mental illness, there's been such stigma and discrimination, as I know many of you know all too well, that these kinds of things get buried and they're not talked about. And the reason why we're really here tonight, so we passed this law to address this historic discrimination in access to care and the fact that consumers were having to pay more out of their own pockets than they do for other medical conditions. So we get the law passed in 2008, becomes fully effective in 2011. But as most of you know from your civics class, getting a law passed, it does not do the job itself. You then have to get regulations that implement and actually actualize the law in people's lives after that. And that's what we're here tonight to talk about, is that the final rules that actually operationalize the law. There have been interim rules that are issued, and they do have the effect of law, and plans are responsible for implementing parity today, but they need to be clearer and they need to be stronger. And so the final regulations have not been implemented. There was an executive order Patrick did a lot of work on this in February after the Newtown tragedy, and it requires the government to issue a final rule by the end of this year. But we need all of you to help us advocate for that and for the strongest rule possible. And so that's one of the reasons why we're having these field hearings all across the country. This is the 13th one. So what does the law do? And I promise this is going to be the only really gobbledygook, boring thing I'm going to go over. The law says that health plans have to offer 6 classifications of benefits. Nothing real, unusual here. Inpatient, in and out of network. Outpatient, in and out of network. Emergency care, and prescription drugs. What we've been finding as we've gone around the country and met with people like you is that because intermediate levels of care, and what I mean by that is an umbrella term for things like intensive outpatient, partial hospitalization, and residential, they're not being covered because they're not explicitly named as one of those 6 classes in the regulations. And so we're asking that by the end of the year that these intermediate inpatient in and out of network will be added in those 3 areas. So what are the big issues that we need to get resolved between now and then? And we need your help on this to help demand change and explain why we need these things. Well, the first thing, and this probably doesn't come as any surprise to anyone, we need transparency and disclosure of how the plans apply various kinds of medical determinations on medical conditions, because parity is all about comparing how a plan treats medical conditions and how they treat behavioral health conditions. And if we don't know how the plans apply it to other medical conditions, we can't do a parity compliance check. And the plans have been very reluctant to provide it. In fact, they're not providing it at all. And we need to make sure a final rule says that they must provide it so that parity compliance testing can be adequately done. There's another unique thing in the federal parity law that is not in any of the state parity laws, and it's this $5 phrase called non-quantitative treatment limits. And all that means is that you can't just have parity in how much people pay for their benefits. You also have to have parity in how the plan medically manages those benefits. And for those of you who are providers, those are things like utilization review and prior authorization and having to fail first at outpatient before you get residential or inpatient. Those kinds of things are those hidden barriers to people accessing care. And what this law says is that they have to be done on par with the way that they manage medical benefits. And the last, and probably one of the most important things and the biggest violations we've seen around the country are the issue around scope of service. And what we mean here is that if a plan offers a huge and vast array of levels of care and types of services on the medical side, they can't then on the behavioral health side say, well, we're going to offer just prescription drugs and outpatient. So if there is a nice array of benefits on the medical side, we believe that this law requires that there be an equally wide array on the behavioral health side. And we are very hopeful, we feel good about the fact that we will get some of these the additional levels of care included in the scope of service requirement. So that's in a nutshell what the parity law requires and what we're trying to accomplish. I did want to mention that parity is also applied in the Affordable Care Act, the health reform law that goes into effect in 2014. And we will have to, see how the final rule goes to see how parity will be applied in the Affordable Care Act. There have been several lawsuits that have been filed. I'm happy to report challenging violations of the federal law. They're going in a positive direction for consumers and families and providers, which is great news. And I see these continuing as the year goes on. I wanted to, before I close, I wanted to make sure that you all knew there are resources out there to help you. We need people to file appeals of denied claims. In that first website, there's a consumer and provider toolkit that helps you know how to do that. If we don't complain when health plans are breaking the law, it continues. And so we need your help in making sure we push back when this law is being broken. The other resources there are places where you can file complaints depending on what type of health plan you have. And that is it. Now you get to have the important part of the night, which is we hear